These are my places of work. I'll start off with the Australian Registry 25, page 523. If you look at it, in 2003, more than 98% of TKRs in Australia were with traditional instrumentation. In 2024, that number has gone below robotic surgery. Robotic surgery now forms the largest volume of TKRs in Australia. This is page 523. Page 524. What does it say? When adjusted for age, gender, ASA, BMI, bearing surface, patella component usage, and stability, there is no difference in the rate of revision when procedures using robotic assistance are compared to traditional instruments. No, I'm not taking Jigar's lecture, but we do need to understand, and more importantly, the last paragraph there, the triathlon CR femur with the triathlon tibia combination shows no difference when procedures using any type of assisting tools are compared, which means that even with Mako, the results are not better. So the preamble for any robotic assistance is, it is not for survivorship, it's for the ease of surgical procedure. Those who cannot remember the past are condemned to repeat it. Let's remember how it all began. In the 1970s, the joint designs and alignment, we were talking of mechanical, anatomic, constitutional alignments. They relied on angles and degrees. And there was a need for technology. Why? Because it was not possible to define the mechanical axis in degrees. Angles were difficult to measure. The paradigm shift came in 2014. After 2014, we started with kinematic and its variants. And the shift was that we started measuring in millimeters, degrees to millimeters. Let's remember, science is not the truth. Science is finding the truth. And hence, the surgeon will change his position from one to the other. If we look at Stephen Howell's journey himself, he started with only patient-specific instrumentation, moved on to only robotics, and now only to manual instrumentation. Now there are papers, kinematic alignment without technology versus mechanical alignment with robots. Femoral accuracy and precision in manual caliper verified KA. And what's the accuracy? 0.175 mm. Most robots struggle to achieve this. What's the instrumentation? Measure the cuts with the help of the saw blade. That is it. This is Stephen Hoffel himself, September 25 in Rome. And his topic was, since TKA is a millimeter-based surgery and not an angular operation, manual instruments are more accurate than robotics. It goes to the point where he doesn't even use X-rays in the OR anymore. He opens the knee, estimates the cartilage and bone loss, then uses manual instruments to take cuts. But the patient population is different. Caucasian anatomy has been well studied. So the preamble for this talk is that robotic assistance is good for ease of surgical procedure. And that is why we need to separate the wheat from the chaff. Different steps of robotics, we have seen that a lot earlier today morning, data acquisition. And we've also known that CT-based is more accurate, saves time, less registration errors. So that is what we would want to pick up. Accurate, saves per operative time, eliminate the company product specialist, have the surgeon in full control. So at this step, the scores are tied. Then comes 3D planning. This is one place which is most affected by artificial intelligence. data processing, and 3D planning. Preoperatively, the CT scan segmentation, landmark selection, and collection of native values, all are now being done by AI. This is an example of segmentation carried out by AI, native values by AI. Even preoperative alignment selection, implant selection, and comparison. For those in teaching hospitals, surgery simulation for residents. You can pick and choose different alignments, mechanical alignment, anatomic alignment, compare. Compare alignments, compare different implants. Because it's an open system, the accuracy of this system, we have published this versus already a published article by Neeraj Adkar and his group in the IJO. Gap balancing. Now, a lot of people talk about gap balancing, but it's important to remember that true gap balancing cannot be done before taking all the cuts. Posterior femoral osteophyte removal, medial tibial osteophytes, posterior capsule release, all of them have a major impact on gap balancing. And that is why when you look at those numbers, 19, 18, 20, each surgeon has developed his own coping mechanism. Most robotic surgeons will leave the knee a little tighter on the medial side to begin with. And then gradually, after the cuts are taken, after the releases are done, it kind of balances. So when that is done only with the pre-operative software, it's easy to revise the cuts. And we have known that bony gap balancing always has been more predictable compared to soft tissue releases. The system allows for UKR planning as well. It allows for hip planning. You can look at the contact areas, various implants, look at the femur, look at the sizes. Once again, here also you can look at the bony contact areas and look at at what is happening to the offsets. The same platform works for shoulder planning, and the key once again is converting degrees to millimeters. 3D planning, AI-driven, surgeon-friendly, no company product specialist, company agnostic. Here, the AI-based AR robot wins. Navigation. Navigation has these 4 important parts.
Manish, can you?
I'll try. We now know that even Mahindra cars have display in the front on the windscreen. So it's time that we started looking at navigation devices in your glasses. And that is what is easy. Because it has no footprint in the OR, there are no line of sight issues. And you can see what you are registering. So yes, for all those who still need navigation, that's the way to go. And then there is personalized instrumentation, which converts those degrees to millimeters, making life simple. That's the UKR jig and the shoulder jigs. Single platform for all, quick, easy, reliable. Nowadays, we have seen a lot of head-mounted navigation devices without 3D digital planning. Why move back? It's like having a body of an SUV with an engine of an Alto. Cutting tools, yes, we know that TKR is an open surgery. It's so much easier. You don't need the burrs for accuracy. When in Ahmedabad, you always talk of 2 Gandhijis. And once again, the AI-based robot wins. We still need robots because it makes life for the surgeon easier. And there you need systems which are applicable everywhere, easy to use. And in 26, the year of Trump, where everything is personalized, you have 3D planning platforms which are personalized, alignment which is personalized, implants which are personalized, jigs, and components of robotic assistance. It's simple. AI-based robots win. Thank you.